to recognize and thank the TB team from the National TB Program. I see we have Mr. Chimzizi, Dr. Lungu. We also have Winnie. So Winnie and Dr. Lungu will actually be doing today's presentation, and they will be supported by Dr. Chimzizi. As you know, UrinLam is part of the package of care for patients with advanced HIV disease, aside other diagnostics for TB. It's a point of care test. So the team will actually demonstrate how to do a UrinLam, when you should do a UrinLam, and what is its role in the general care for patients with HIV, especially with advanced HIV disease. It's not for everyone, it's only for specific patients. Dr. Lungu and Winnie, please go ahead. You're welcome, please introduce yourselves.
Thank you very much, Tombo, for that introduction. Indeed, we greatly appreciate the ECHO team for choosing this very important topic. As introduced, I think before I go any further, I also just want to say that we equally invited Dr. Chavala, who is a consultant pediatrician, to support us in this important topic. So Dr. Chavala will take it up from the perspective of the use of LAM in children. So just to indicate that we greatly appreciate the generosity as well as the call by the ECHO team to bring this important topic to the fore. I think without much ado, I would like just to say that Winnie, I'll support Winnie in terms of the presentation. So Winnie will start, and thereafter I'll come in with a clinical presentation on the indications for LAM. So Winnie, over to you to start the presentation.
Thank you, Dr. Lungu, and good afternoon, everyone. Kindly confirm if my screen is visible on your end.
We can see your screen very well, Winnie, so well done for that. Please just put it in slideshow and we are good to go. Thank you. Just to mention that this is a collaboration between the Zambia College of Physicians and the ECHO program. Dr. Lungu and I are actually executive members of the Zambia College of Physicians. So we are particularly grateful for everybody that has joined us on this network.
Thank you. So I'll go ahead and start with this presentation. So what is LAM? LAM is basically a urine assay. It is an immunocapture assay based on the detection of the mycobacterial LAM antigen. So this rapid strip is actually embedded with antibodies that will capture the LAM if it is present in that urine, and it is applied to the strip. When it runs through, when it is present, it will be captured by those antigens that are embedded on this strip. That is what it means when the assay is referred to as being an immunocapture. So that capturing happens and the reaction happens, and then you see the result. So this is an instrument-free point of care test, and it delivers results within 25 minutes. And it is suitable for use at the bedside. So you get results and make decisions very quickly. Just as an overview of the LAM, so LAM stands for Lipoarabinomannan. This is a component of the cell wall of the Mycobacterium tuberculosis, and it is released from metabolically active and degenerating bacterial cells. So if this antigen or the bacteria is present in a person's body and they are metabolizing, this LAM will get released. And in patients living with HIV and advanced immunodeficiency or disseminated TB with renal involvement, LAM can now be present in the urine. And this is how this assay has importance in terms of utility in this category of patients, because then it is possible to detect it through their urine that gets passed out. And as we know, in this category of patients, usually they will not have respiratory symptoms, and a sputum is usually not usable, or they actually fail to produce, they don't produce sputum when TB is disseminated. So urine becomes a very critical specimen, and that is why this test also becomes very important and possesses a very important place within the cascade of screening for TB. So what are the requirements for us to be able to do this test? So all we need is a urine specimen and a urine LAM kit. Well, these are procured and they are supplied to all facilities. For the urine, all we need is just one specimen, and this urine should be stored in the refrigerator for up to 72 hours. If the test is not done immediately, it can be refrigerated for up to 72 hours and it will still give good results. If not refrigerated, then the testing must be done within 8 hours. Otherwise, the heat and conditions, the moisture may lead to disintegration of the LAM and it may not be detectable. So if the test is not being done immediately, the urine should be stored refrigerated. And all we need is just 2 to 5 mils, and that specimen will be good enough to be used for this test. For the kits that we receive, these cards must be stored. Basically, you can refrigerate them at 2 degrees to 8. They can also be stored at room temperature. So they are stable between 2 and 30 degrees until the date that they expire. So we cannot use expired kits. If the devices have become wet or if the package is broken, then we should avoid using such kits, as if they have sucked up some moisture, it may affect the reaction from happening properly. So those are just the requirements, just a urine specimen and a test strip. That is what we need to be able to carry out this test. Here, we are just highlighting methods for collecting urine from children. And this being a month where we are focusing on childhood TB, we just thought this needed to be highlighted. So there are several ways that we can use to collect urine from babies that are sick for us to be able to use this urine for the LAM test. You can use a urine bag, a clean catch, voiding stimulation, a catheter, and suprapubic aspirate. Whatever method is appropriate, depending on the condition of the baby, all those methods can be applied. This is just to illustrate the steps that are done or taken to do a LAM test. So the test is performed manually by applying 60 microliter, which is equivalent to 2 drops of urine to a determined TB LAM antigen test strip. And then this strip, after you've applied your 2 drops of urine, you incubate it for 25 minutes. And after those 25 minutes have elapsed, the strip is then inspected by eye. And then the intensity of any visible band on the test strip is graded by comparing it with the intensities on the bands on a manufacturer supplied reference card. So the kit comes with a card that shows different intensities in the coloring of the bands, and that is just to show how much LAM, it relates to the concentration, how much LAM is in that urine, and they are graded from 1 to 4. However, any intensity is regarded as a positive. So the reference card includes 4 bands, grade 1 representing a very low intensity band to grade 4 representing a high or dark intensity band, but all bands, as long as we see a band, that represents a positive LAM test result. So at this point, I'm going, after having talked about how the test is done, I'm going to show a video that will show us in real life how a test is being done in one of the facilities. Please watch the video.
My name is Esther Perry. I'm a nurse here at UTH and the TB clinic. So this is the test clinic where we see all our TB and MDR patients. So today I'm going to talk about the urine lab tests, which we use on the patients who we suspect of having TB but are unable to produce sputum. We use it mainly on the patients, unconscious, and maybe they have some signs that they could have TB. So we do the urine lab on them.
Hi, Winnie. Hi, Winnie. I'm so sorry to interrupt you, but I can see that you it's really, really slow on your, it's buffering actually on your side. Is it okay if I try to share from here?
If you have the video, please, you can share, then I'll just continue.
Let me see how it will do, because it's buffering.
Okay.
Yeah, you may have to stop sharing your screen. Is this the one? Oh, this one. Okay, let's see how this one goes. Uh-oh. What's happened? I can't see myself. You need to come on. Stop sharing. Where is it? Where is it called? Okay. Is that you? That's you? Oh, Kote. You find me because this is when. Okay, Winnie. There's no volume. We can't really hear, but Winnie, are you able to talk through people as Esther is doing this test? Because we can't hear Kote.
So can I go ahead and share my screen again, then I can talk through? Or we could skip and watch that video at the end.
Sputum. We use it mainly. I'm a nurse here at UTH and the TB clinic. So this is the chest clinic where we see all our TB and MDR patients. So today I'm going to talk about the urine lab tests, which we use on the patients who have who we suspect of having TB but are unable to produce sputum. We use it mainly on the bedridden patients, those may be unconscious, and maybe they have some signs that they could have TB. So we do the urine lab on them, and they should be HIV positive. So today I'm going to show you how it is done. We usually do the test from this clinic. This is the chest clinic where we do it from. So I'm going to demonstrate to you how we go about to do the urine lab test. So this is the negative test. Yeah. So now I'm going to conduct the tests, the urine lab tests. So these are the things, the equipment that I use. I need the pipette to collect the urine from the specimen bottle. I also need the test. This is the thing we use for testing the urine, the strip. So I'm gonna open it. Opening, we do it like this. When you open it like that, you have to put it, you have to lay it flat like this. Then I'll open my urine and get the pipette that we use to collect the urine from the specimen bottle. Then I'm going to put 2 drops right here. 1, 2. The rest, I'll put it back. So I'm going to discard this.
Don't use words.
And close the bottle. So we have waited for 25 minutes now. So this urine, I forgot to mention, it was gotten from the patient, our OPD, outpatient patient. So that's why we have done the urine from here, chest clinic. For the patients in the wards, we do the test from the treatment room. So the results are now ready. These are the results. As you can see, there's only one line there, meaning that the test is negative. So this patient does not have TB. So when you have the 2 lines there, meaning the patient is positive. So for now, our result says the patient is negative. So this patient, we cannot start them from TB treatment unless their sputums are positive or the X-ray is not okay. So these are the results. So we waited for 25 minutes. So as you are doing this test, make sure when you get the urine to get the good results, you have to wait for 25 minutes to get the correct results. So we are done here. I'm going to discard both my urine and the strip, and I will record my results in the patient's file. So just a bit more to elaborate more on the test. As I mentioned to say, the positive test has to have 2 lines on the strips. So meaning the patient has TB and that patient will be initiated on treatment. But if it is negative, there is only 1 line, meaning the patient is negative. Those we don't initiate on treatment unless they have any other test like sputum test or X-ray results. So I would just like to talk about the lung. It has really helped us a lot, especially for the patients who are in the wards. Those who are unconscious and those who have been bedridden, those who are unable to cough. We have really been using it. Like for the past month, we had about 40 urine lung positive that we started on treatment. Yes, they were unable to produce sputum, but after using their urine lung, we were able to detect the TB. So I think it has really, not thinking, but it has really helped us in terms of TB diagnosis. So we would encourage maybe more supplies of the sticks so that we don't run out. That way we will not be able to miss TB on the patients who are unable to produce sputum and unable to do the X-rays. Thank you.
Thank you so much, Esther. Winnie, you can please go ahead with your presentation.
Thank you. Let me just share again.
Am I the only one who thought the patient needed to drink water? That urine was very concentrated.
Yes. Yeah, so we've just seen how the test is done, both in theory, we've described it, and we've had a chance to see it being done in real life at UTH. So the results, this is how the results are interpreted. A positive, that means we've seen 2 bands on the strip, and that means MTB was detected from the specimen. Therefore, the patient has bacteriologically confirmed TB. If the test is negative, MTB was not detected from the specimen. Just put it in. Sorry. Yeah. So what are the benefits and limitation? Like every other test that we have that we are using in our network, LAM also has benefits as well as limitations. So the benefits are that this is the only test that has shown to reduce deaths. And unlike traditional TB diagnostic methods, LAM demonstrates improved sensitivity in seriously ill HIV-infected individuals, especially in those with low CD4 count. And of course, this is because in this category of patients, the disease will be more of a disseminated type of disease as opposed to being pulmonary. So there's no production of sputum, or if they produce the sputum, it will actually be negative. So this has demonstrated additionality in terms of detecting cases in this category of patients. And it is aimed at the most vulnerable. It's affordable, it's non-invasive, it's very fast and simple to perform, as we have seen. The limitations are that it's got very low sensitivity. It does not provide information on drug susceptibility, unlike the expert does. It can't be used for treatment monitoring, and the population in which it is useful is limited to those that are HIV positive, and Dr. Lungu will delve much on that. LAM cannot distinguish between Mycobacterium tuberculosis, which causes TB, and other types of mycobacteria. So this antigen that we are detecting with this assay is found even in those mycobacterium that are non-tuberculous, the NTNs. So that way, of course, that will mean there will be a few false positives, but of course, with the if we stick to the type of patients that we are targeting, and of course, it means that we are suspecting TB in these patients based on other factors. Therefore, it is very reliable in that regard if we use it strictly for the population for which it is indicated. And other considerations that need to be noted when we are using LAM is that the detection of mycobacterial LAM antigen in urine does not provide drug resistance. This also appeared in the previous slide. Implementation of LF-LAM in the targeted population groups does not eliminate the need for other diagnostic tests, as these tests have better diagnostic accuracy. So we need to put in mind that when we are using LAM, it doesn't mean that we ignore all other tests, the sputum, other fluids, if they are available, they need to be taken for gene expert as well. The culture, we should not forget all those other tests when we are using LAM. It's an add-on test for us to diagnose TB. And when possible, a positive LF-LAM should be followed up with a confirmatory test. It will be important that even these patients that we have diagnosed using LAM, we need to make all efforts to have a test done that gives us information on drug resistance, so that these patients are put on appropriate treatment. And LF-LAM is designed to detect mycobacterial LAM antigen in human urine. Other samples, therefore, sputum, serum plasma, CSF, and other body fluids will not be usable on LAM. It's only designed to detect LAM, and that LAM is secreted mainly in the urine. So we should not use this LAM with other specimens other than urine. So from this point in the presentation, Dr. Lungu will take us through indications for use of urine LAM. Over to you, Dr. Lungu.
Thank you very much. Winnie, you could move to the next slide. Yeah, so colleagues, I'm happy to take you through on the indications for LAM. But I think before I do that, let me just emphasize on one point, that the principle behind urine LAM is that it's essentially the shedding of part of the cell wall of the Mycobacterium tuberculosis bacilli. And part of that cell wall is called Lipoarabinomannan, in short, LAM. And this component is excreted as waste material through the kidneys. And it is passed out through urine. Remember, the waste from the kidney is essentially urine. So what this means is that it does not really mean that when LAM comes out positive, then the person has TB of the kidneys. Not at all. But it's just the excretion of the disintegrated part of the cell wall, which is the LAM itself, being excreted through urine. And the assay essentially then, which is the urine strip, then detects the presence of that component. And when it is present, then it comes out to be positive. I thought we should all understand the principle. And I wanted just to emphasize that. So therefore, then this brings us to the reasons why we request for urine LAM and in which patients it's indicated. So by and large, urine LAM test is indicated in those who are severely ill. I think it is in that population in which these studies were done, and it was seen to be more sensitive in individuals who have advanced HIV disease. The reason being is that they have a lot of mycobacterium which they are shedding off, so the likelihood of the test being positive is high. And it is for this reason where now the confusion comes about that when LAM is positive, it essentially means that someone has disseminated TB. It may not be necessarily true, but in most cases, that's what the case is. So you find that LAM is indicated in all patients who are presenting with pulmonary disease and all patients who are presenting with what we may suspect to be extrapulmonary disease. And also highly sensitive in patients with a CD4 count below 200. It is for this reason that Winnie mentioned that it is one of the TB tests that has been found to be life-saving. Life-saving in the sense that it prevents mortality, and prevents mortality in the sense that it is the only test that is likely to be positive when there's advanced disease. Your gene expert is going to give you a false negative. Chest X-ray findings may be negative, may not be indicative of TB. So your last line becomes urine LAM. And the reason being why it's more sensitive, I think I earlier mentioned that patients with advanced HIV disease, be it those with a stage 3 or stage 4 by WHO standard, or those with CD4 count of less than 200, these ones have low immunity, and because of that, they have increased number of TB bacilli in their body. So they will be essentially shedding off the LAM in large quantities through urine, and it's going to be positive. So the last point to take on the CD4 count, it is irrespective of the signs and symptoms of TB. So your moribund patients who are living with HIV, those failing ART, fall in this category. And that's for the inpatients. Now for the outpatients, LAM is equally indicated in persons living with HIV. And most outpatients tend to have a much higher CD4 counts because they are a bit much healthier than those who are inpatients. But still, there are those, LAM is still indicated to be utilized in outpatient setting. And again, the target populations are those who are seriously ill or those with CD4 less than 100 cells, irrespective of the signs and symptoms. They don't necessarily need to be moribund. So this is for those who may not have any stage 3 or stage 4 defining illness, yet they have a CD4 count of less than 100. Remember, at a much lower CD4 count, certain people may not even show any signs. So it is for this reason that we are bringing in the cutoff point of 100. I hope you understand this issue. Yeah, the third group in which LAM is indicated are the under 5 malnourished children. Remember the relationship between TB and undernutrition, and more especially in children. TB is closely related to undernutrition in the sense that TB causes undernutrition itself. And on the other hand as well, undernutrition predisposes the child to having tuberculosis. Last but not the least, in which group of patients LAM is indicated, are patients with chronic kidney disease. The point to take here, colleagues, again, is a point of immunosuppression. Chronic kidney disease patients are immunosuppressed. And the form of immunosuppression is that it affects their T cell function. As a result of this, these individuals become susceptible to TB. And more often, they will not show the typical signs of TB. So in this regard, we can extend of LAM to exclude TB in this patient, especially when they have a septic infection, when they have a septic condition, when they are mounting a fever. We can include urine LAM as part of the workup. Chest X-ray may not be that informative. Gene expert may not be that informative, but still we must utilize the other tests besides LAM in this population. So I thought I should emphasize that LAM is indicated in patients with chronic kidney disease. So these are the indications for LAM, and I think the points to undertake on kidney disease is that it is irrespective of the HIV status. And secondly, irrespective of the CD4 count. So in this regard, LAM is indicated in children who have undernutrition irrespective of HIV status, and secondly, in chronic kidney disease irrespective of their HIV status or CD4. Dr. Chavala may amplify on the indications of LAM in children, but I thought I should mention that. So there are points also to undertake is that while LAM is indicated in other populations, to a large extent, let's utilize it in those with HIV disease. We can move to the next slide. So colleagues, I think the other points to take note is that to support you in terms of evaluating who qualifies for LAM and also how to interpret the results for LAM is that we have this algorithm. Winnie, perhaps you could just enlarge so that people can understand, can be able to see the algorithm properly. It's a bit blurred. So, like earlier said, LAM is indicated in all age groups. And also just to place an emphasis in children below the age of 5 and chronic kidney disease, irrespective of HIV status. So one of the things that the other groups also we have considered are patients who have sepsis. and sepsis as well, regardless of the HIV status. But all HIV patients presenting with sepsis, we should test them for TB. I'll give you the other reasons why we should do so. There was a study done here in Zambia by some of our colleagues, one of them being Dr. Mchemwa. And one of the things that he found in that study done at UTH is that over 34% of patients who presented with septicemia, the cause of that septicemia was actually TB bacteremia. So essentially the cause of TB the cause of sepsis in those patients, about 34% of them, the cause was TB, and mortality was over 70% within the period of 48 hours. So it is for this reason that we have included sepsis. It was not part of the WHO recommendation, but putting in the country context and from our own experience, we have included patients presenting with sepsis. The other patient category were earlier mentioned. So irrespective of HIV status with signs and symptoms of TB, so essentially anyone presenting with signs and symptoms of TB, if they are moribund, they have septicemia, they have moderate acute malnutrition or severe acute malnutrition or CKD group stage 4 or stage 5, LAM is indicated. Persons living with HIV positive for TB signs and symptoms. It may be either symptoms or signs. And these are the additional criteria where they have sepsis, where they have a CD4 count of less than 200, and those having CD4 count below 100, like I mentioned, the outpatient. So on the other side as well, we have people living with HIV with no TB signs or symptoms. And these are individuals who are presenting with sepsis. And the other staging of HIV by CD4, as earlier mentioned. So what we need to do now in all these three broader categories is that we need to collect the urine sample. And from there, if the urine sample as directed in the video that you just saw, if it is positive, immediately initiate treatment. Immediately initiate the treatment based on the patient's history. Colleagues, history is very, very important. Let me emphasize this. If someone tests LAM positive and they're contact of a TB patient, of a DRR TB patient, the likelihood that you're dealing with drug-resistant TB in that patient is very high. I think Winnie, in her presentation, she mentioned that LAM does not rule out DRR TB. It's not structured for that purpose. So you may, based on the history of that, contact history of that patient, you will put the patient on an appropriate regimen befitting the history of that patient. But one of the other things that we know is that we have other tools to utilize. So all patients who are testing positive on LAM should have their sputum collected and tested with a gene expert to exclude rifampicin resistance. And it's for the reasons that I earlier mentioned, that LAM does not exclude or inform us about drug susceptibility. So at least with a gene expert, we'll be able to detect rifampicin resistant and assign the treatment for that patient appropriately. For patients who are testing, who have LAM negative status does not mean the patient does not have TB. Remember that LAM has its own strength and also has its own limitation. And one of its limitations is that its sensitivity is equally limited. It's around 70 to 80% thereabout. And I also, like I mentioned, it also depends on the bacterial hue that is in that patient and the level of the CD4 count. Essentially, it's impacted by the level of immunity. So it is for that reason that we still need to have a higher index of suspicion and utilize other tests. So we should also be very careful how we communicate the negative LAM test to patients. I will emphasize on that point for the simple reason is that if you tell the patient that they do not have TB based on a urine LAM, and in one way or the other, another test comes out positive, you risk getting conflicted with the patient in the sense that the patient will say, I was initially told that I do not have TB based on the urine test. How come I'm being told now that I have TB based on where is this coming from? So it creates a lot of doubt, and some conflict may arise in our communication with the patient. So the point that we should all take note that the current LAM test does not exclude TB if it tests out negative. I thought I should labor on that point. So when LAM is negative, you initially suspected TB, make sure that you explore other tests, gene expert, chest x-ray, to collect other fluids, and also subject the sputum or any other fluid to at least LPA and culture as well. So your culture will be your last end. And at times I also say culture may also come out negative due to other issues. So culture also does not say when it's negative, it's totally negative. Winnie can qualify that as she comes on with the presentation. There are times when we over-sterilize the specimen and it ends up testing negative.
Yes, she also updated the soft copy. We might need to, once we've done them here. How many did we manage to put in?
Sorry, we're getting some feedback.
Oh, wow.
Perhaps you could help us mute the
Intimate partner violence. So those that come saying my husband beat me, my wife beat me, as long as it's someone that they're intimate with. Okay. And then,
Sorry about that. I'm really, really sorry.
No, that's fine.
Yeah, but we've managed.
Okay, so we can continue. So in an event, LAM is positive, and you started the treatment and you collect your gene expert and it comes out RR positive, you need to adjust the treatment based on the gene expert. So instead of continuing with the first line drugs, this is a patient that you move to the second line drugs. Essentially, you're moving the patient to MDR. So when you have, there are other options that when you are, all methods have shown you that this is not TB, treat the patient based on the conditions or the clinical presentation. Essentially here we are saying that treat the patients for other conditions befitting the patient status. I hope I've helped you run through this algorithm. Next slide. So what I would just encourage all of us is that let's make a print of this algorithm and stick it in our screening rooms. And where you have questions, please reach out to us. So colleagues, this is another point I think I will spend some time on because I think we need to get it right. What we have observed is that there's been some misclassifications of patients on whom we diagnose TB using LAM. Misclassification in the sense that from TB side, we have two classifications. One based on whether we have confirmed TB using the biological means, and also second by site of disease. So let me start with site of disease. As I mentioned earlier on, that when urine LAM is positive, it does not really mean that the patient has disseminated TB. who has extrapulmonary TB, or rather renal kidney TB. It just simply means that person has a much higher bacterial load and is able to shed the urine, the lamb from the cell wall through urine. Are we together? So in terms of the site of the disease, it will be determined by the clinical presentation. So if a patient is presenting with pulmonary symptoms only, as well as from your physical finding, there are no extrapulmonary features indicative of TB, such as matted lymph nodes, an acidic or swollen gibbous, or an arthritis. In that case, that patient has pulmonary TB. But that TB is bacteriologically confirmed using the lamb. I hope I'm not confusing you. The second classification, or the area classification that we use, is the biological status. And here we talk about whether it's bacteriologically confirmed or clinical. Clinical is where a patient presents with signs and symptoms and posts a chest X-ray that is indicative of TB, or they have a gibbous, or they have matted lymph nodes. In this case, or you have a patient with an acidic fluid that is straw-colored and an ADA that is elevated, adenosine deaminase that is elevated, or use other criteria, or even with CSF, which shows a high lymphocytic count and a high protein. In that regard, you can say this is clinical TB. But you have not really confirmed TB, but the presence of TB using either a gene expert, using microscopy, using culture, or using lab. Whenever any of our microbiological tools test positive, that patient is bacteriologically confirmed. And LAM is using biological principles, and biological means to diagnose TB. So when LAM comes out positive, this patient must be classified as bacteriologically confirmed. And lastly, in terms of the site of disease, it's based on the clinical features, and the clinical features may be symptoms, signs that you see. So a person with TB can be bacteriologically confirmed and have either pulmonary or extrapulmonary. So a LAM positive is not a clinical diagnosis. It is bacteriological. I thought I should qualify the source. From this point on, colleagues, all patients who are positive by LAM are bacteriologically confirmed cases. And we assign the site of disease by their clinical presentation. I think this is where I end, and I call upon Winnie to complete the presentation. Winnie, over to you.
Thank you, Dr. Lungu. So this is the last slide, actually, and we just want to bring out the key messages to take home from this presentation. And these number one, that LAM is not a replacement for rapid molecular diagnostic tests. So it is an add-on test and should not replace all other investigations that need to be done to make a diagnosis. Secondly, is that LAM should be used for diagnosis in recommended patient groups only. So we need to stick to those category of patients, the HIV, patients living with HIV, who have advanced HIV disease as per algorithm, and also other outside the HIV positive individuals in under 5 malnourished children, as well as patients with CKD irrespective of the HIV. Thirdly is that LAM should be used for diagnosis only and not for treatment monitoring. So LAM will not be used to monitor treatment. A positive LAM result is a bacteriological confirmation of TB when used on recommended patient categories. And this last statement should not confuse us, but should remind us, like what we said, that this LAM, the antigen, is present also in non-tuberculous bacteria. And so the patients should be well selected. That is what we are trying to say, based on history, based on other presentations that make a high suspicion for TB. So if there's high suspicion for TB, this is a bacteriological confirmation of TB when the test becomes positive. Lastly, a negative LAM test does not exclude TB, and all other investigations and decisions should be made accordingly and not based on a negative LAM strip test. Thank you. I think this is our last slide.
Thank you. Thank you so much, Winnie. Thank you so much, Dr. Lungu, for that very clear presentation on the lateral flow urine lipoarabinomannan assay. So that's what the urine LAM is about. There is a question here that says, what is the sensitivity and specificity of the urine LAM? What is the sensitivity and specificity of this test? Please, if you have any questions, just raise your hands. We'll unmute you. Dr. Lungu, what is the sensitivity of this test? How sensitive is it? I know you had a slide up, but you said it's actually not very sensitive. But I think somebody is looking for some numbers.
So maybe I can take that up. Sensitivity is around 40%.
Okay, so it's only 40% sensitive, so that's not very high. I know Zenith's hand is up, but there was a question from Eastern Province. They are saying, why are we not extending this to more than 2 districts? They say in Eastern Province, only 2 hospitals have this. Winnie or Dr. Lungu, would you want to comment on the supply and availability, in short, access of this useful test to facilities?
Yeah, thank you very much, Chair. So I think when we started the urine LAM, we started with the bigger hospitals. And it was for the reason of just managing the commodities. And remember, even in the indication that we've discussed, that LAM is highly indicated in those patients who are moribund with advanced disease. That's where you get the highest sensitivity. So we did not want to, so we were and these patients are mostly found in the bigger hospitals. And now that we have adequate commodities, so all provinces are now encouraged to decentralize the use of LAM. So we can now expand to other additional districts and additional facilities as well, because at least the stock levels of urine LAM is a bit more now and stable than where we are coming from. So the underlying statement there now is that all provinces, let's decentralize the use of LAM to other districts. And also not only in inpatients, but also extend it to OPD as well.
Thank you so much, Dr. Lungu, especially that this is the month for ending childhood tuberculosis. And we heard that now it's actually approved for use in pediatrics. We'll ask Dr. Chabala a question, but we'll allow Zenith to go ahead with a question. Zenith?
Thank you so much, moderator. Good morning, network. Good afternoon, network. And thank you to all the presenters. My contribution is on the classification of the cases detected through LAM. I'm happy that Dr. Lungu has made it very clear on the classification. What I want to contribute is that for people, especially those that are entering information in the registers and the writing on the treatment cards, it would be very nice if clinicians or whoever is clerking the patient put up very good notes to ensure that all the information is in the notes and people are able to pick the type of this TB case, whether it will be under pulmonary or it will fall under extrapulmonary. So thank you for that clear guide, Dr. Lungu, on that one. Sometimes the notes are not really very clear, so it will be difficult for people to classify whether pulmonary or extrapulmonary. Thank you so much.
Thank you so much, Zenith. I just realized I actually know. Benson, please mute your mic. May we please mute Benson? I just realized that I actually know Zenith very well. We work together in the Eastern Province. She's a TB expert. She's seasoned, and that's very clear. As Esther mentioned in the video, Zenith is emphasizing it's about documentation. UTH was one of the first facilities to use urine lamp, and us as clinicians, we did do very well because our documentation was poor. So you noted what Esther said. You document in the patient file. You also document so that you hand over to the lab and they know that you have tested, so that they can get you more urine lamps. And also you say whether it is pulmonary or extrapulmonary. It's very clear that it's bacteriological, but this is very, very important in terms of programming. So thank you very much for that, Zenith. Very, very important. As clinicians, we are not very good at documenting, unfortunately. We'll be seeing urine lamp in our facilities. Please, let's write in the file, the urine lamp is positive or the urine lamp is negative. We also inform the lab so that we are able to account for the sticks. Python Mooney, please go ahead with your contribution. Mr. Python Nguni. Python Nguni. Okay, so Mr. Python is not ready. He's muted his microphone. So Mlenga Boalia is asking this question to you, Winnie. They wanted to find out about monitoring of TB using LAM. Can you monitor using LAM? The question is in the chat box. Yeah, so somebody is asking about monitoring. I know you talked about it, Winnie, but do you mind repeating yourself?
Yes, we cannot use LAM to monitor treatment, unfortunately. So it's not recommended to use LAM to monitor treatment. So treatment will be monitored using other modalities. Microscopy actually is the tool that we use for monitoring, as well as culture for DRTB patients. Over.
Thank you so much, Winnie, and I see Abraham has followed up with affirming that you cannot use it for monitoring because it will be positive anyway. It may take long to clear because it's from the cell wall. As we know, Python Nguni, your hand is up and your mic is unmuted. Do you want to say something?
Yes. Good afternoon.
Yes.
Thank you very much. Wanted to find out, are there factors that which can affect the procession of LAM samples?
Oh, that's a very good question. Extremely important because that impacts your result. I know Winnie talked about it. What are the factors that can affect the urine that you are sending for urine LAM, whether you are doing it from your lab? Ideally, it's a point of care, it's a bedside, but some facilities prefer the urine is taken to the lab. So what are some of the factors you should look out for so that you don't end up with a false negative or a false positive? Winnie?
Thank you. So when we discussed requirements for the urine specimen, emphasis was on storage. So your urine needs to be refrigerated. If you won't be able to do it in 72 hours, keep it refrigerated to maintain the integrity and the structure of the LAM protein. This is a lipopolysaccharide, so it will disintegrate with temperature. So it needs the critical issues are to maintain, to keep the urine refrigerated. If you do not have a refrigerator, the test must be done within 8 hours if you are storing it at room temperature. So if there's no Access to a refrigerator, the test must be done within 8 hours. If the test cannot be done within 8 hours, the specimen must be refrigerated. In other settings, if there is need to store the urine for longer, for instance, if a facility is waiting for lung strips and they have this urine that they need to test, it can be frozen. So the SOPs that we have in facilities in terms of lab processing or lab procedures for LAM, they are more elaborate. That SOP will talk about samples that can be refrigerated for longer periods. And it also elaborates how then you process that sample that is coming from, from being frozen to be prepared for testing. So all that information is there in the SOPs. So temperature, storage temperature is very critical for this sample for you to get, for us to get good quality results.
Yeah. Thank you so much for telling us about sample transportation and management. The ideal situation is the patient urinates, you do the sample there and then. Really, if you must stretch, you can now allow 8 hours, but the best urine is fresh urine. So avoid urine that is in the catheter because you don't know how long it has been there and it can actually lead to misinterpretation. Again, this is World Childhood TB Month. So we are raising TB awareness in children. And I'm sure you noticed that now urine LAM has been approved for use in children. Dr. Chabala, would you like to speak to this? What does this mean for the TB pediatric world in particular, especially that I know you can now use stool? How does this improve your care of patients, Dr. Chabala?
Thank you, Dr. Foloshi, for this opportunity. Yeah, the biggest challenge, as you know, in pediatric TB is bacteriological confirmation, and therefore having more and more options to achieve that is a good thing. So the inclusion of LAM as another option in addition to stool, so this does improve the capacity for us to do bacteriological confirmation, which has always been a challenge. And I think if you look at the LAM, it's pretty much understandable that that it probably would have utility in children, because in adults it's indicated for adults with HIV as who have HIV infection, and in particular those that have severe immunosuppression. And you know, the common understanding is that the manifestation of TB in children is very similar to the manifestation of TB in HIV infected adults. So it makes sense that the LAM should be, should find utility in children. But however, we understand that the LAM has limitations. The sensitivity in kids is just around 50%, and also the specificity is just about 82%. So when we're using it, we have to bear those things in mind. And also we have specific groups that I think Winnie and Dr. Lungu indicated that for now is being shown to be to be more reliable. So those that are HIV positive, children with severe acute malnutrition, and the under 5s, and also those with severe TB disease. So we should always be mindful of trying to use the LAM within these contexts. And then again, like any other TB test in a child, the LAM should always be used in conjunction with the other information that's available. So the clinical history, the physical exam, and any X-ray support should always come into context when we are interpreting results of a LAM test in a child. The other issue that I wanted to bring about is that particularly the groups that we are earmarking for the under 5s and the malnourished, this is where we may also face challenges in getting a urine sample, and therefore we should also be mindful of the drawbacks that you may have for LAM in a child. So for example, because they are smaller children, you may resort to using a urine bag. And because they are small children, when they pass urine, that sometimes can be contaminated with the fecal material. And therefore, we were already told that other mycobacterium can cross-react with LAM. And therefore, if the stool sample is, if the urine sample is contaminated with stools, especially in smaller children where we're using a bag, we may actually find that you may get a false positive test. And therefore, it's just being mindful that when you're going to collect a urine sample in a smaller child, you make sure that you have a clean sample. So if you're using a bag, you make sure that the child's perineum is cleaned before you place the bag. And if you're using the other methods, you just take caution that there's no cross-contamination between the urine and the two samples. And so, yeah, I think those were the main points that I thought I should highlight regarding the use of LAM in children. Thank you so much.
Thank you so much, Dr. Chabala. We really appreciate. We will not dilute that because we are honoring the Childhood TB Month. Dr. Chabala is seasoned in TB, and we thank you for those additions. And as Dr. Lungu has mentioned, this test is available. Let us push our pharmacists to order so that we are using it for our patients. We have a pending HIV drug resistance session that we'll be holding very soon. There's some data we're looking at. With that said, we want to thank you all. Thank you to the network. Thank you, Dr. Lungu, Dr. Chabala, and Winnie for the presentation and for clarifying and sharing with us the algorithm. Thank you all.
Thank you.
Thank you. Thank you very much.
Thank you.